Hello, everyone. My name is Megan Pollier, and I'm the Clinic Partnership Manager here at MAVEN Project. Thank you all for joining us today, and our friends over at Clinica Sierra Vista for hosting today's session, which is called Successful Management of Gout in the Primary Care Setting by Dr. Robert Goldfien. Dr. Goldfien worked as a rheumatologist at Kaiser Permanente for over 28 years. And in addition to his clinical practice, he held roles as Chief of Medicine at Kaiser Richmond, Chief of Rheumatology for Kaiser East Bay, and Chair of Rheumatology for the Permanente Medical Group. He is currently consulting in rheumatology at 2 community clinics in San Francisco and Marin County, California, and he has an interest in inflammatory arthritis and in the management of gout. So thank you, Dr. Goldfien, for today's presentation. I'll go ahead and hand it over to you.
Thank you. Welcome, everyone. I hope this is useful for you. I'm going to talk about gout and in particular about things that you can do in primary care to manage it. I have no disclosures. This is the accreditation information you just heard. Learning objectives. So my hope for this talk is to help you learn a little bit more about treating acute gout, but also managing chronic gout. And maybe try to reframe how you think about gout a little bit. More specifically, I'm going to talk about the epidemiology and increased prevalence of gout and why that's the case. We're going to talk about recognizing gout as a chronic metabolic disorder, distinguishing the treatment of an acute gout flare from management of chronic gout and hyperuricemia. And at the end, I'd like to show you a way to apply a target-oriented approach to managing serum uric acid. So gout is a chronic condition in which hyperuricemia leads to the accumulation of crystals, sodium uric crystals in joints and other soft tissues. Clinically, as you know, it presents typically as an acute, sometimes very severe, and usually, at least early on, self-limited monoarthritis or flare. Most commonly, it's in the first MTP joint, but it can also occur in many other joints and especially the midfoot, ankles, and sometimes the knees. Over time, it's often the case that patients with gout have an increased frequency and duration of gout flares. And in severe cases, you may actually see tophi, which present as subcutaneous nodules, which aren't typically painful. Epidemiology, gout is the most common inflammatory arthritis in men, and it's about 3 times as common in men than women. You contrast that with rheumatoid arthritis, which is at least 3 times more common in women than men. As with many things, there's an increased incidence of gout with age. And the incidence does vary worldwide. In the US, it's higher in some Asian populations, Asian Pacific Island populations, and more so recently in Black Americans. The incidence has increased greatly in the last 30 years. Between about 1980 and 2010, the frequency of gout or the incidence has increased 2 to 3-fold. Not coincidentally, there are frequently comorbidities in patients with gout. About 75% of patients with gout have hypertension, at least 30% have diabetes, and about 30% have stage 3 or more CKD. To understand this, these are all conditions which affect uric acid excretion and tend to reduce uric acid excretion in the kidneys, which is what leads to the hyperuricemia. Since those conditions have increased in frequency over the past 30 years, the incidence of gout has increased with them. To talk about dieting gout, I want to point out one thing that's really important, which is that, everybody I see with gout asks me about diet. Diet is perceived by by gout patients and to some extent by physicians and other practitioners as being strongly associated with gout, in particular foods that have high levels of purines and therefore elevate serum uric acid. These include seafood, organ meats, alcohol, soft drinks with high fructose corn syrup also do that incidentally. And legumes are a bit of a special case. Legumes indeed do have purines in them, but studies have never shown that legumes cause uric acid to go up or increase gout flares. So while patients may identify that as something they've been avoiding, it probably isn't necessary. Dairy products probably lower serum uric acid a little bit. And then again, I'd like to stress diet is a factor in gout, but it's really not helpful to think of it as the cause. It's really a triggering factor. So, when I take care of gout patients, I spend some time answering their questions about diet, and I give them some, basic general health advice with that. But I don't focus on diet as the treatment. Diagnosing gout, it's often a clinical diagnosis, and what I mean by that is that although crystal identification in joint fluid is the definitive way to diagnose gout and useful if you can do it, it's not always practical. If gout is in somebody, if someone has a gout attack in their big toe, I rarely have tried to stick a needle in that toe to get fluid out. It's just, I think of it as just being too painful. So if the clinical picture fits, and if the serum uric acid is high, then we make a clinical diagnosis of gout and then you can treat. Um, it's possible for the serum uric acid to be in the normal range when someone comes in with a gout attack. But it's almost always high in untreated gout. And when I say high, I mean above about 6 or 6.5 mg/cent, which is the level in the serum that causes uric acid crystals to form. So if someone's never been treated and they come in with an acute arthritis and the serum uric acid is 4 or 4.5, at that point, I'm pretty unlikely to think that this is gout. Um, Patients with gout have a typical pattern of acute, episodic, severe arthritis. Unlike other forms of chronic arthritis like rheumatoid, which can vary somewhat from week to week or month to month, patients with gout, when they get over a gout attack, the pain is gone and they have no pain for many, many months, even sometimes until they have another gout flare. So it resolves completely in especially early gout. As far as imaging is concerned, plain radiographs probably won't show any abnormalities in people with relatively recent onset gout. There are some changes you can see in severe, prolonged or long-term gout, which are sort of periarticular erosions. Ultrasound and CT can both be used to identify gout, but it's really not practical in most settings. There are ultrasound findings that you can do with bedside ultrasound that can be characteristic of gout, and a type of CT scanning called dual energy CT can actually show uric acid deposits in the joints. When I was at Kaiser, I wasn't able to convince my radiologist to buy the software to do that programming, so I never used that. Family history is worth asking about, and in particular, patients who present with gout at a young age, or 30s, I have found very, very frequently have a family history of gout. Most likely they have some sort of genetic inheritance that affects the uric acid transporters in the kidney. So that's common, especially in young patients with gout. So if you see a typical picture, I would say it's okay to treat it as gout acutely and then do the workup you have to do. Um, Finally, there's been a sort of a history of people telling you not to get a uric acid level when someone's having a gout attack because it can actually go down during a gout attack. My habit is to get it anyway. It's going to usually be high anyway if someone has gout, and you may not get another chance to check it if the patient gets better and doesn't come back. Okay, treating acute gouty arthritis. I'm imagining all of you have done this. And these are sort of just some tips that I would use or say. The first thing is to treat early, and I'm using the term aggressively in quotes, meaning if someone comes in, there are different options for treating them. They include NSAIDs, colchicine, oral steroids. ice actually has been shown to reduce the pain in gout of application of ice. Um, and the treatment options may be limited by comorbidities such as diabetes and CKD, which are, as I've said above, common with patients with diabetes. But early and aggressively means start someone on treatment right away. And when they leave the office, make sure they have either colchicine or NSAIDs to treat the next time they get it and to treat as soon as they feel the symptoms coming on. And I tend to use high dose NSAIDs if I'm going to use NSAIDs, meaning, the equivalent of maybe 50 milligrams of indomethacin 3 times a day for 1 or 2 days, and then tapering ibuprofen 800 milligrams 3 times a day, and then tapering. Low doses just may not be strong enough to control the symptoms. One other pitfall that I've seen over the years is the patient stopping the treatment too soon before the symptoms have really been completely eradicated. I tend to think of it like a smoldering fire. If there's still some minor symptoms, um, uh, they can flare up again with stopping treatment or any other, dietary things. And if someone's been having frequent or persistent symptoms that haven't responded to the initial treatment, you may have to put them on a prolonged course, even for several weeks to get rid of it. And often this involves using prednisone. So treat early and aggressively. Um, I'm going to talk about the specific treatments in more detail. As far as NSAIDs are concerned, indomethacin has been the traditional NSAID used. And I mentioned a dose of 50 milligrams 2 to 3 times a day, and then tapering over 5 to 7 days. But other NSAIDs also work. And the main thing is to don't hesitate to use higher doses initially. I tend to use a shorter acting NSAID for acute gout, and that would include indomethacin, but it could also include ibuprofen. The idea there is that a shorter acting NSAID may actually work more quickly than a longer acting NSAID like meloxicam, for example. So a short acting NSAID, high dose, taper, but continue it until the symptoms are completely gone. Prednisone is a useful treatment for gout. It's highly effective for acute gout. It's usually not our first line treatment, but it might be the first line treatment in somebody with renal disease, for example, who you want to avoid NSAIDs or too much colchicine. And so that's a good choice in that regard. And I usually start with 40 milligrams daily for 3 to 4 days and then taper by 10 milligrams every 2 to 3 days until the symptoms are controlled. You can also use prednisone if someone's been on NSAIDs and not responding well enough, you can switch them to prednisone. Okay. Intra-articular steroids actually work well, but again, it depends on where the joint is involved. If it's the knee, you could do that. But even in those cases, I don't usually use that. I usually use oral prednisone. Colchicine is a traditional treatment for acute gout. It's been used for, gosh, in some form or another for many, many, many years. It wasn't approved for the treatment of gout by the FDA until 2010, interestingly enough. But at that point, the FDA had sponsored some studies to look at its effectiveness and found that it was effective. The one thing the FDA did, however, was they put out a recommendation for a different treatment regimen than had been traditional. The traditional treatment regimen that I learned in my career early on was to use 1 tablet of 0.6 milligrams every hour for up to 6 tablets until either the pain was gone or the patient had cramping and diarrhea. However, my experience was that most people ended up with cramping and diarrhea. And so I will use colchicine, but I'll do it the way the FDA now recommends, which is 2 tablets of 0.6 milligrams, and then followed by 1 tablet an hour later, and then up to zero point 0.6 twice a day for 2 to 3 days. That works for a lot of people. If they have colchicine and are comfortable with it, that's a good choice. So And colchicine you should avoid in patients with CKD stage 4 or more, at least as an acute treatment. It can build up in the system and cause serious toxicity in people with renal failure. Okay, I want to switch from treating acute gout to managing chronic gout and hyperuricemia. And um, my little moniker for this, for um, my aphorism, is that gout is a chronic metabolic disease dressed up as arthritis. Historically, we've all spent a lot of time dealing with how to manage acute gout in the ways I just went over a moment ago. But really, the best way to manage gout is to consider it a chronic condition and treat it that way. And that requires using a systematic approach that's target oriented, in which one uses uric acid lowering medicine and monitoring of serum uric acid. The analogy I use for this, and I talk to my patients about this because many of them, can understand this a little bit better. I think of managing hyperuricemia the same way as we manage hyperlipidemia. And the idea there is that when we're treating hyperlipidemia, we're not doing it because hyperlipidemia causes any direct symptoms. We're doing it to prevent coronary artery disease later in life. So similarly, managing gout is done through lowering uric acid, but that's not because a high uric acid causes any direct symptoms. It's to prevent gout attacks in the future. So the way to manage it is to treat the underlying metabolic abnormality. Um, so the key to managing gout, therefore, is keeping the serum uric acid under the level where it causes crystals to form in the blood and in the tissues. And that level, we usually use the level of 6.0 milligrams per deciliter as the target for managing gout. Um, it turns out that urate lowering therapy is highly effective and is effective in almost all patients in achieving this target dose if it's escalated and titrated properly. Um, what makes treating acute chronic hyperuricemia and gout more difficult than hyperlipidemia is primarily the fact that lowering the uric acid level initially won't get rid of the gout attacks right away. In fact, there's many studies that have shown that there's actually a little higher rate of gout flares when we put people on uric acid lowering medications. Um, and to understand that, you just have to think about the fact that there's still a lot of uric acid in the joints. And as long as there's uric acid crystals in the joints, it's possible to have gout attacks. What tends to trigger gout attacks is fluctuations in the serum levels that can sort of mobilize the crystals into the synovial fluid and trigger a gout attack. So putting a patient on uric acid lowering medicines can actually involve having a gout attack in the short term and somewhat increase risk of gout for at least 6 months or more. And that is why we use what we call flare prophylaxis. It's generally recommended if you put someone on urate lowering therapy that you keep them on a low dose. Usually colchicine we do once a day or so for at least 6 months in most patients. You can also use a daily NSAID if someone can't take colchicine, as long as they get monitored appropriately in terms of renal function. Um, and it's important to prepare the patient for the possibility that they'll have gout flares. I don't know how many times I've seen someone who was put on allopurinol and stopped it 2 weeks later because they had a gout flare and they concluded that it wasn't working. Um, so you must prepare your patients for the idea that they can still have gout flares for the time being, but that they need to stay on the long-term medication. Uh, in a related way, medication non-adherence is very common. That's what I just described as one reason people stop the treatment. But more commonly, people, after they've been feeling well for a while, they have a way of just deciding that they don't need the medication anymore. The consequence of that is if you're going to successfully manage hyperuricemia, it's important to periodically monitor the serum uric acid. And finally, the first line treatment for urate lowering therapy is allopurinol. And unless it's contraindicated by the presence of a gene called HLA-B5801. And which brings me to talk about allopurinol hypersensitivity syndrome. This is a severe and potentially fatal allergic response to allopurinol. It's it's been feared over the years by physicians who've, either seen this, although it's rare, or just basically heard about it. It is pretty uncommon, about zero point 0.3 in 1,000 patients, and it usually occurs in the first several months of treatment. So notably, the risk of this is much higher in people who have a gene called HLA-B5801. This turns out to be a little more common in patients with certain ethnic backgrounds or nationalities. Chinese, Korean, Thai have an increased prevalence of that gene. And the ACR, the American College of Rheumatology, recommends screening these populations for the gene. The HLA-B5801 test is available commercially, and it can be ordered. And the current recommendation is to check that before starting allopurinol, in particular in these Asian populations. It's possible this recommendation may change in the future, as we get less tolerant for, taking unnecessary medication risks. It's not out of the question that there may eventually be a recommendation to or to test everybody for that before starting allopurinol. If someone is HLA-B5801 positive, the first line drug for hyperuricemia is febuxostat, also called Uloric, which is also a very effective treatment. And also, even though it's rare, it's a good idea to let people know if they're starting allopurinol that to be alert to any rash or fever if the medication after starting the medication, and call and stop the medication if that happens. Those are early signs of that syndrome. Okay, so to be a little more specific about how to use urate lowering drugs, what I typically recommend is most people can be started on 100 milligrams per day of allopurinol. If someone has CKD, especially CKD4 with a GFR of less than 30, most rheumatologists would say start on allopurinol 50 milligrams, and then titrate up and monitor the serum uric acid as a guide. I'll go over some specific sort of protocols for how to do that. The important thing with this titration is the goal should be not getting someone on a certain dose of allopurinol, but actually the goal is to achieve a serum uric acid of less than 6. And that's almost always possible with allopurinol. I will show you some more specific data about dosing and how that affects the titration. In terms of second line treatment, if you do use febuxostat, it's generally started at 40 milligrams per day. It comes in 40 and 80 milligram tablets, but 40 milligrams a day is a good starting dose, and then monitor uric acid. I mentioned flare prophylaxis earlier, so if you're starting someone on allopurinol or febuxostat, I would make it kind of a default to use daily colchicine, 0.6 milligrams per day, especially for a normal GFR. If the GFR is a little bit low, you could do it every other day. If a patient doesn't want to do it, it's not mandatory, but you should just let them know that they have less of a chance of getting gout flares if they do that. Finally, if someone does get a gout attack when they're taking urate lowering treatment, they have to be treated just as any other patient with a gout flare. But don't stop the urate lowering treatment, because that'll cause fluctuations in the uric acid level, which can trigger worsening flares. So I have commonly seen people come in and say they had a gout flare and they treated it, but they went off their allopurinol when they started treating the acute gout flare, and that's not a good idea. You just stay on it. Okay, so when I was at Kaiser, I actually did a lot of primary care, and we had some chronic conditions management programs that we started there that used nurses or pharmacists managing chronic conditions like diabetes, hypertension, hyperlipidemia with physician oversight. Um, and we followed our patients using this sort of leverage care model. At some point, I kind of realized that we could use a similar approach for treating hyperuricemia. And so I started a clinic and let my colleagues in primary care uh, refer patients with gout to me. And I set up a protocol to use with a pharmacist for managing hyperuricemia. And I want to show you this protocol for a couple reasons. One is because it actually gives a good sort of schematic for how to manage hyperuricemia and how to monitor and target the proper uric acid level. But also, we collected a lot of data on these patients, and I think it's very illustrative to see what happens when you put people on these urate lowering treatments. So this was actually the protocol. Um, I set up a system that patients could be referred to what I called my gout management clinic. If they were in the middle of a gout flare, then we would treat the gout flare just as described above. Um, and if not, we would then go to the next step and start urate lowering treatment. Again, this would have been, in most cases, 100 milligrams of allopurinol daily. After 2 to 3 weeks, we would have the patients come in and check the serum uric acid level. And then one of two things we would do. If they weren't at goal, they would revert back up to the upper box again, and they would titrate the uric acid treatment up to 200 milligrams of allopurinol. 2 or 3 weeks later, we would check the uric acid level again, and we would repeat this process until the uric acid level was below 6. And if once that was achieved, we would have them do that for 3 months and then check the uric acid level again. And then there was another opportunity if they weren't at goal to go back up and start and titrate the urate lowering therapy, sorry. It wasn't meant to be a long-term intervention, and so when people were at goal, we would discharge them from the clinic back to their primary care provider. So this was the protocol we used, and we treated, I think, maybe close to 100 patients using this, and then tracked what happened to these patients. And this was the result of that treatment in terms of looking at the serum uric acid levels. If you look at this, each one of these pairs of blue and red bars represents one patient. So this is all the patients that we treated. And the green line that goes across is 6.0 milligrams per deciliter. The red bar is the uric acid when we started the clinic or when they started in the clinic. And the blue bar is the uric acid level when they were discharged from the clinic or at the last one measured. So if you just look at this, you can see that the vast majority of these patients actually achieved the target goal of less than 6. There were a handful of people who didn't, typically because of non-adherence, and I'll show you a little data about that in a moment. But this just illustrates that this approach is effective in controlling serum uric acid levels. And there's nothing, written in stone about the exact time frames and protocol, but the basic idea of starting the medicine, checking the uric acid, titrating the medicine, checking again, and you doing that till you're at target. It's not unlike how we manage other chronic conditions, diabetes with hemoglobin A1C targets, hyperlipidemia with LDL targets. Same idea, and it's really no more difficult. I show you this analysis because it gives you a little more granular look at what happens to individual patients when you do this. So this was 20 of the 88 patients, I think it was, that we essentially randomly selected and then plotted their own uric acid levels measured during the clinic or during the protocol. And what you can see is if you look at time 0 on the left side, all the patients were above 6 when they started in the clinic. And the first thing you see is that all of the patients dropped their serum uric acid levels when they were started on allopurinol or in a few cases febuxostat. my experience with allopurinol is a little bit like what you see with statins, which is that they essentially always work. If someone takes the medicine, if someone takes a statin, their cholesterol comes down. If someone takes allopurinol, the uric acid comes down. And so how far it comes down and whether it stays down has almost always to do with the dose and the adherence to the treatment regimen. The other thing that jumps out at you with this is a lot of these people rebound back up at some point or other, sometimes early on, sometimes later in the clinic. And what we found with this is, essentially this is what happened. People would take the medicine and then sometimes they would stop taking it. But since we had them come back in to recheck their level, we could see that they were taking it and we can start them back on their treatment. And so at the end, um, and the maximum duration for this clinic was 12 months. By the end, the majority of patients were at goal. There were a few that were close to goal, but not quite there. But the bumpiness of this graph really gives you some insight into how patients, deal with taking these medicines. They don't always stay on them. And the key is to track them so you can tell when they stop the medicine and you can encourage them to restart. I mentioned dosing of allopurinol before and that it was almost always possible to get people to goal. What this graph shows is this is just a histogram, and this is not percentages, but this is the number of patients who were at uric acid target levels, meaning less than 6, on a particular dose of allopurinol. So on 100 milligrams per day, there were a couple of patients, maybe 3, who actually were at target. 200 milligrams, there were closer to 18, and 300 milligrams, by the time you get to 300 milligrams, about 2/3 of these patients were at goal. But 2/3 is not 100%, and it took more medication to get the remaining patients to goal. The highest dose we had to use for this clinic was 600 milligrams. And sometimes instead of going from 400 to 500, I would have people go from 400 to 450 and use 1.5 tablets of 300. The point is that it's different. There are different levels, doses of allopurinol that are required to get someone to goal. And the the way to approach this is to keep raising it until they get to goal. The FDA, just for some context, the FDA approved the use of allopurinol to treat hyperuricemia in doses up to 800 milligrams. So I don't think I've ever had to use that much, maybe 750 once. The reason this is important, and it just has to do with the fact that one of the things that we traditionally see in management of hyperuricemia is that someone will put a patient on 100 milligrams or 300 milligrams of allopurinol and just leave it there and not really follow up and see what the result was. So if you do that, if you put patients on 300 milligrams, about 2/3 of them would probably be a goal, but a significant number won't. Okay, so that was this protocol we used, and it illustrates sort of what the landscape looks like when you try to treat people for hyperuricemia. I'd like to end with a couple of case studies just to illustrate some of these points or to put them in a more concrete context. So this case is a 47-year-old Chinese male who comes in with a third gout flare in the past year. He's already been told to avoid certain foods and to take colchicine if he gets gout flares. He had an elevated serum uric acid level of 8.2, but that was measured 2 years ago and had not been repeated. His PMH is notable for well-controlled type 2 diabetes and hypertension. He's on lisinopril and low-dose aspirin. When examined, he has a tender and swollen red left midfoot, which is a common place to get gout. And then the question is, what do you recommend? How do you treat this patient? So here are some options that I put out for you. Option A is to start colchicine 0.6 milligrams times 2, and then repeat an hour later and then continue at 0.6 BID for up to 3 days. Or alternatively, start indomethacin 50 milligrams TID for 2 to 3 days, and then taper it. Option B, tell him to stop his aspirin because aspirin does raise serum uric acid levels. Option C, start him on allopurinol, 300 milligrams per day. D, have him get a serum uric acid level, serum creatinine, and an HLA-B5801 gene test. And E, tell him to eliminate red meat from his diet. So these are, on the face of it, all potentially good options. But here's how I would have probably done this. I would have, yes, started colchicine or indomethacin to treat the gout attack, no question. Um, that's always necessary when someone comes in with acute gout. Would you tell him to stop his aspirin? It's a bit of a trick question. Stopping his aspirin probably would help his uric acid level come down a little bit. But I have found that if I start someone on allopurinol and treat them appropriately, being on the aspirin won't prevent me from getting to goal. And if he's on it for a good reason, for primary or secondary prevention of heart disease, I don't think it's necessary to tell him to stop. I would just get him treated for his hyperuricemia. C, should you start him on allopurinol 300 milligrams per day? Well, I already said before that it's generally a good idea to start with a lower dose and titrate. So I wouldn't do that. But in addition, in this particular case, since he's of Chinese ancestry, I would definitely have him get a serum uric acid level and creatinine, which he hasn't had for a long time, or at least not the uric acid level, and an HLA-B5801 gene. Tell him to eliminate red meat from his diet. I don't tend to be very dogmatic about that. My sense about diet is that if you eat things in moderation, you're going to be fine in most cases. I think that, for example, with alcohol, um, I think if my patient wants to have a beer every day, that's fine. But I think if he wants to have six on every Saturday, that's probably not a good idea because that'll perturb the uric acid level more dramatically. So I don't necessarily tell people to eliminate red meat. If they want to do it, it's fine. But I tell them to, eat a little bit. Don't have a porterhouse steak. Second case is what I'm calling refractory gout. And this is a 57-year-old male who comes in with two recent gout flares affecting the ankle, the left and then the right. He's been on allopurinol 300 milligrams daily for some time, but he had actually stopped it a few months ago, and then he restarted it when this flare occurred. He took indomethacin with the recent gout flare, but he's still having ankle pain. His medical history is notable for CKD3, his GFR at 54, and he has hypertension. On exam, he has a tender, mildly red, and swollen right midfoot and ankle. And his last serum uric acid 6 months previously was 5.7. So what do you recommend in this patient? So these are options for you. Um, First one would be to stop indomethacin and start oral prednisone, 40 milligrams per day, and taper over about 10 days. Next, stop allopurinol. Uh, Third option, continue allopurinol and start daily colchicine, 0.6 milligrams per day after the prednisone is completed. Increase the allopurinol dose to 400 milligrams per day. Would you do that? Educate the patient that he needs to continue allopurinol long-term to eliminate gout flares. And repeat the serum uric acid level in 3 weeks. Those are the options. So my answers in this patient are, I probably would stop the indomethacin and start oral prednisone. Patients who have had sort of recurrent flares over a brief period of time or haven't resolved completely, I think often just need a stronger anti-inflammatory. So the prednisone is a good option for this patient. Most people tolerate, a 7 to 10 day course of prednisone fine, especially if you're tapering it. Should you stop allopurinol? So no, I would not stop the allopurinol. Would you continue it and start daily colchicine? That I would do. I would continue the allopurinol, the dose he was on before, and daily colchicine 0.6 milligrams as prophylaxis for further flares. Should you increase the allopurinol dose to 400? Well, the answer to that is sort of buried in the case report. he had a normal uric acid level when he was on the allopurinol before he stopped it. It was 5.7. What that tells me is that that was a perfectly good dose for him. He doesn't need to increase it. He just needs to take it and keep taking it. So that means you do want to educate the patient that he needs to continue allopurinol for the long term to eliminate gout flares. Um, and along those lines, I I try to be a little more concrete about this if I can. I'll say, I'll say to someone, look, your blood pressure medicine you're taking long term, right? You know you have to take that long term. Think of this as like your blood pressure medicine. It's just you're just gonna have to keep taking it because if you don't take it anymore, it stops working. Um, and and then I would repeat the serum uric acid level in 3 weeks. Repeating the uric acid level is good to, verify that they really are at goal. But in general, having someone get an occasional uric acid level is a good way of just sort of making sure they're still taking the medicine. Because if they come in and their uric acid level is back up to 7 or 8, essentially what you know then is that they're not taking their medicine. And you can call them and say, please go back on your medicine. So occasional monitoring is really good because people often are non-adherent and they just eventually stop the treatment. So those are the cases. And I guess at this point, I will open it up for any questions that you might have.
I see two questions in the Q&A box, and just a reminder, everyone, you can type questions in the Q&A box, or if you'd like to directly speak or ask your question to Dr. Goldfien, you can raise your hand and I can unmute you. But the first question here is, what is your maintenance therapy program, chronic treatment with colchicine and Benamid?
Hmm. Well, so I don't use Benamid very much, but it does work. And if someone can't take allopurinol or febuxostat, uh, Benamid, it's usually twice a day. It could be 500 or 1,000 milligrams, but the basic idea is the same. I mean, you titrate the dose up until the uric acid level is below 6, and then the patient has to stay on that dose. As far as colchicine is concerned, um, if I'm using colchicine as a flare prophylaxis, um, I try to recommend that people do that for at least 6 months. I let them know that unlike the probenecid or the allopurinol, that the colchicine is not a lifelong medicine. It's just a good idea to take it for the first 6 months, um, just so you don't have as many gout flares. I will note in this context that there was a recent paper that actually showed that daily colchicine can reduce gout flare frequency even up to a period of a year, but it's not a dramatic difference. And so I usually tell people 6 months, and then they can go off the colchicine and stay on the probenecid or the allopurinol. I hope that answered your question.
Okay. Next question is, are you concerned about urate kidney stones?
Um, so urate kidney stones can be an indication for using urate lowering treatment, um, allopurinol. Now, in this case, there's a little stronger sort of theoretic basis for using allopurinol rather than probenecid because probenecid will increase urate trans.
Recurrent attacks involving the same joint, do you see joint change? And if joint change is identified, is this temporary or considered permanent, even if properly treated?
How long it takes for you to develop joint damage that's visible on an X-ray. The typical findings are an erosion of the joints, actually not quite on the joints, are these erosions, then you'll see with, for example, rheumatoid. years and just never been treated appropriately. Um, an erosion like that, will not revert to looking normal on an X-ray, but it doesn't function. They won't revert back to normal, but stop progressing.
Cool. Any other questions? And a reminder, today's June 3rd, and your speaker was Dr. Robert Goldfien. And thank you all for joining us. We're more than happy to give you some time back in the day. Someone said excellent, very informative lecture. Thank you very much.
All right. Have a good day.
Bye, everyone. Thanks for joining us.